Cervical cancer remains the fourth most common cancer among women worldwide. And we know now that the majority of these cancers are due to a virus, human papillomavirus. While early stage disease can often be cured with surgery or chemoradiotherapy, the advanced or recurrent cervical cancer continues to have a poor prognosis. In the United States, approximately 13,000 new cases of invasive cervical cancer are diagnosed, and 4,200 women die from the disease each year. While incidence rates have declined significantly over the past several decades due to widespread screening and the HPV vaccine, cervical cancer remains a highly prevalent health issue. So today, as you might guess, we are exploring this highly preventable and treatable cancer, which is still causing significant morbidity and mortality in women across the globe. Welcome to GynoCurious. I'm your host and creator, Dr. Amy Novatt, a board-certified OBGYN. From both sides of the speculum, we're here to investigate what it means to be a healer and to be healed. Please follow and share the show wherever you listen to your podcasts. And please, if you are interested in learning more about my clinical practice, go to dramynovat.com. Today, I am so pleased to welcome Dr. Miriam Cremer to the show. Dr. Cremer is a board-certified OBGYN and also has a master's in public health and is currently an associate professor of obstetrics and gynecology at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. Dr. Cremer is also the president and founder of Basic Health International, a charitable organization whose vision is to create and implement cutting-edge research, treatment, and advocacy so that no woman dies of cervical cancer. Welcome, Miriam.
Hi, thanks. It's really good to see you.
It's so nice to see you. So just to let the audience know, this is going to be a science-y show today. Sometimes GynoCurious goes into the more esoteric. I really wanted to bring Miriam here so that you could learn really all that there is to know about cervical cancer, HPV, and how Basic Health International, or BHI, is working on investigating and advancing the science around this problem throughout the world, and how much Miriam and her colleagues at Basic Health have really changed the lives of so many, many women. So I'm so proud. I'm so proud to be in the room with you. Yeah.
Thank you.
So I always like to start with, okay, why an OBGYN? Why did you become the doctor you are?
When I was a college student, I went to Hampshire College, which sadly is
I
closing,
know.
and I had the chance to do a rotation in rural Nicaragua.
Mm.
And at the time, I thought I wanted to study alternative agriculture. So I did a semester abroad in a rural community in Nicaragua, and very quickly realized that I could not. So I was put in the field with all men. I didn't really speak Spanish, and I did not have the physical strength to do the work that they did.
Mm.
And then got to work with a woman that was a natural healer. And we gave out tinctures and did acupuncture on her porch. And I just had an aha moment. Like, if I could go to medical school, I could have some skills and really make a difference in the world.
Mm. I
So,
love that pivot because, I've talked on GynoCurious about how hard, demanding residency is, but perhaps the physicality of working in agriculture is just a little bit more.
I mean, there is just, it was comical, but
Yeah, yeah, great, great. And so you went off to medical school, you realized you wanted to do OBGYN, you went to OBGYN residency, but then you had this experience somewhere along the line where Basic Health International became another aha moment. Can you tell us about the kind of origin of the organization?
yeah, I actually was a medical student and I did a rotation in a rural community in El Salvador. So when I was there, I went with a healthcare promoter who took me everywhere with her. It was actually like a formative experience for me. This little town was a sister city of Madison, Wisconsin, and I was warmly welcomed into the community, which was pretty amazing because during the Civil War, the people in Madison had been there and they felt like very supported because at the time, if like people internationally were physically there to bear witness, a lot less violence would happen. So there were these women that had just been through so much in their lives. And I was totally embraced to come into the community. And you know how little we know as medical students, but there was a phenomenal nurse that we took coolers of vaccines into communities to do vaccination campaigns, and the doctor that came in would come in only a couple days a week from the city, and the rest of the time it was me. So I got to see all sorts of things and attend births, and it was really amazing. And we visited a woman in her 30s with young children that wound up bleeding to death from cervical cancer.
Oh, gracious.
And I was like,
Mm.
gosh, that is not a thing that should happen. We have the tools, but they didn't have anything at the time. So we did some organizing and got women to come in to do their pap smears. And I remember the number exactly. We did 86 pap smears in all these little cantones. And I brought them back in my luggage and got the pathologist at the university to read them, and then called the only telecommunication center at the time. It was like the only place you could go to make a phone call. And I called the operator. I was like, okay, we have these 13 positive cases, and I'm coming back on this date. And I went back, and it was the rainy season. And I said I was going to be there at 10 a.m. And we didn't wind up getting there till 2 p.m. because the roads were all washed out and it took so long to get there. But all 13 women were there waiting
Wow.
get their follow-up, which is pretty amazing.
Yeah, yeah. I really admire your perseverance. I mean, as a medical student, you've got some other things going on. You're studying, you're trying to just keep up with that. So to be so inspired and diligent in following up and bringing these pap smears home. I mean, it's a great story. It really is a great origin story. And I want the audience to know that I've been fortunate to travel with Miriam and Basic Health International. Not enough, but enough
Yeah.
to see how this organization has just blossomed and grown. And Miriam and I are going to talk a little bit more about that towards the end of the show. But I want to kind of just go deeper into cervical cancer
Yeah,
and
sure.
why hearing this story about a 30-year-old woman bleeding to death from this cancer is just unacceptable and should never have happened. So, cancer as a disease was recognized several thousands of years ago. And there have been different theories of the cause of cancer that have evolved over time, but none considered an infectious etiology until the 20th century. Viral etiologies for animal cancers was first discovered in 1908, but it took many more years for the eventual discovery of the first human tumor virus, or what we call oncovirus, which we now know causes approximately 12 to 20% of all cancers worldwide. So these viruses are some that you've heard of: Epstein-Barr virus, hepatitis B, and the papillomaviruses, for example. And what's interesting is these were only first identified in like the 1960s and 1970s. So viruses and other infectious agents are the second largest preventable cause of cancer, right behind tobacco, which I think is really fascinating
Wow.
because there's been such an interesting move to eliminate tobacco smoking. Although I just came back from Europe where everybody was smoking, it's uncanny. This information seems to have gone to the wayside. But the fact that there is these oncogenes, these viruses that we know about and can identify, and now impact the incidence and prevalence of these diseases is so, so important. So, Miriam, I'd like you to start with, if you would, just talking about human papillomavirus or HPV and how it's related to cervical cancer. Can you tie the two together for our audience, please?
Yeah. So the HPV viruses, actually, there are over 100 different types of HPV viruses, but there are 13 high-risk HPV viruses, which cause 99% of all cervical cancers. And even more specifically than that, not only would we know that these 13 types cause nearly all cervical cancers, types 16 and 18 cause 70% of cervical cancers worldwide. We have the causative agent like down to a T. And
Remarkable. Yeah.
really importantly, there was a study in Syracuse, which I think is not so far from you,
No, just north of us. Yep.
that showed 77% of college age women have high risk HPV. So young women, like it's like a common cold. Everybody gets HPV and many people clear it. However, persistent high risk HPV types can cause precancers, which last for 10 to 15 years. So we have a good opportunity to treat those precancers before they develop to invasive cancer, which is why this is such a compelling public health problem.
Yeah, yeah. So I want to remind the audience that when Miriam talks about all the different virus types, you might hear about strains, 16 and 18 strain. That's just another word. So I just want to make sure that's really clear that, it's an HPV type. And sometimes people will get very confused about these numbers. And, what's most important, of course, is that your clinician is investigating for these high risk types. And what I want to just talk about, I'd be curious how you deal with this conversation. When I tell women in my clinic that while most sexually active people get HPV, as you just described, the majority of them, the HPV clears. And it's only when the HPV is persistent that these changes occur in the cell that can become cancer. And people are like, I don't get it. So you mean every time, having sex alone is the problem? And I kind of say, well, yes, it's that prevalent. And I use the same expression. I said, it's like the common cold, that prevalent. And then they're like, well, then it means I'm going to get cancer. No, that's not what it means. But it's a really hard for some people to really dissect oh, you're telling me I have a cancer producing virus, but yet I may not get cancer. Can you kind of unravel that a little bit? Because people do get confused about it's so prevalent, but yet maybe it's not a problem. Can we talk about that?
Yeah, definitely.
Yeah.
So, almost everybody gets HPV at some point in their life. We don't even test for it under age 30. So that's important because it's so prevalent in young women, we would do unnecessary procedures if we tested under age 30. But when it lingers, there are a couple of risk factors of who might be more likely to persist or develop into invasive cancers. We know smoking is a risk factor that leads to invasive cervical cancer, and people who are immunocompromised, like women living with HIV. However, the majority of cases that persist do not have risk factors that we can identify. So it's not really clear who is going to persist and why, which is, a scary conversation. But I can reassure patients who come in, I do colposcopy clinics, that, as long as you're getting your follow up, as long as you're coming in, we can treat the underlying precancer. It's highly unlikely that you'll progress to invasive cancer.
Yeah. So you've said a couple of important things. So first, I want to just articulate this concept of pre-cancer. I mean, I've had colleagues who even misuse that term, and certainly patients do a lot. Sometimes they've actually had cancer and they called it a precancer because it was an early cancer. But precancer in this setting, again, are changes in the cellular architecture that are not cancer. They are not cancer, but they're changes that we know that can over time evolve to cancer, correct?
That's right.
Yeah, and it's really different.
Importantly, they can also regress to not
Yeah,
even the very high. We classify precancers into low medium, and high grade. And even the highest risk ones sometimes will go away on their own.
That's right. That's right. And we don't completely understand that either. What causes spontaneous regression? So the other thing that often happens is somebody might say to me, "But I've only had two partners. How can I have this STI? I'm not promiscuous." Tell me how you'd respond to that
Yeah,
inquiry or that
anybody can get
concern.
HPV. It just takes one partner, one
That's
active
right. That's
intercourse.
right. Yeah. Yeah. So again, I want to reiterate that to those listening, if you've been told you have HPV, it doesn't mean you've made poor decisions. It doesn't mean that you are having too much sex, although I don't even know what that means. But I guess the question that also comes up is, Dr. Cremer, I used a condom. We used a condom every single time. How is a condom affecting HPV transmission or the incidence?
I mean, it can certainly decrease the transmission, but it doesn't take it away altogether. So it's one of the STDs that is not entirely preventable by condom use.
Yeah, yeah. So, for a very long time, especially when you and I were training, women would say, "I'm going for my pap smear." They wouldn't say, "I'm going for my annual GYN." They just say, "I'm going for my pap smear." And then over the last decade, it's changed where pap smears and their role in screening and how often they're utilized has evolved and changed. Can you talk about the pap smear? And then we're going to interface it with the screening for HPV. But let's start with the pap smear because that's what everybody thinks of their gynecologist and they think of pap smears.
Yeah, they do.
Yeah.
So, the PAP was a fantastic invention. I mean, it saved thousands of lives. It became in wide use in the 50s in the US. And it's basically scraping some cells off the cervix, putting them onto the slide, and the pathologist reviews them for precancerous changes. And we used to think that we needed to do this every year. So now, like, the guidelines I think are very confusing, even for providers. But now we say we should start screening for cervical cancer at age 21, but from ages 21 to 30, women just get PAP. But if it's normal, it only needs to be done every 3 years. And then after age 30 to age 65, you can get a co-test with both a PAP and an HPV. Because what we've learned about the biology, I don't even know if when I was in medical school, we were positive that all causes of cervical cancer were from the HPV virus.
For me, no. I know during our residency, we had very little understanding of HPV. Yeah.
So the science has just exploded in this area,
Yeah.
which is pretty amazing.
It's remarkable, particularly since GynoCurious speaks a lot about how the science on women's bodies is so far behind the science on male bodies. So this is a place where there's been remarkable advancements. And much to your credit and organizations like BHI that are kind of just pushing it forward internationally as well as within our own country. So again, when you go to your gynecologist out there, they're going to talk depending upon how old you are, how often you might need a pap smear. That doesn't mean that's only when you go to see your doctor. You might need to see your doctor annually for other reasons, but that the pap smear may not be done every time you see your gynecologist. And then the advent of the HPV test, because as Dr. Kramer pointed out, if 99% of cervical cancers are due to HPV, then if we can screen you for HPV, that's going to really help guide your care, how often you're seen, whether you need other interventions. So you said 99%. What happens with the 1% that don't seem to have HPV? Do we know anything about those cancers?
Yeah, that's a great question. I mean, I used to think they probably were HPV or just HPV we didn't see. And it's a good question. I still kind of think that, but it's hard to know. I mean, I think it's over 99. It's like 99 point something.
It's a very small percentage, but as much of the science that I've read, there is always a percentage of those cancers that we just have not seen HPV. Yeah. And, who knows, maybe those other risk factors, the immune compromise, the smoking, are sufficient to change cellular architecture. But it's very, very curious.
Or another virus, who knows, that we don't know.
Exactly. Or an HPV subtype or strain that we just don't know how to test for, that it comes off differently in the assays, et cetera. Yeah. So again, for those of you out there, we are not saying don't get PAPs. We're saying that you may need PAPs less frequently than annually, and that the role of the HPV test is incredibly important. And there's even some guidelines that are suggesting that maybe just the HPV test be done and not the PAP. But again, this is an evolving set of recommendations, and there are several governing bodies that are trying to really look at the science and best guide clinicians and hence the women out there.
So the science is really clear. Like, we really could just use HPV testing, but we've been so attached to the pap smear, we will go to primary HPV testing. I think within the next, 5 years or so.
Interesting.
Um,
Uh-huh.
I think all of Europe, they do primary testing. I think we're really one of the only countries in the world that does co-testing.
I didn't know that. That's fascinating. So it's really just the vestiges of the language and the ritual of doing PAPs when you see your gynecologist that's kind of lingering here.
Yeah, and I can
Interesting.
give you some numbers. We looked at a year of co-testing at the Cleveland Clinic. There were
Hmm.
220,000 co-tests done. And of those, there were 42 that had high risk cases without HPV positivity. So we're trying to look into those 42 cases to say, well, did they have it and we didn't catch it? Did they ever evolve into any kind of precancer or cancer? But the numbers are very, very small, even right away.
Yeah, yeah. It will be very interesting to hear what comes of that investigation. It's curious. It's in science so often it's an interesting kind of bidirectional phenomenon. Our brains are kind of moving forward, but the science hasn't gotten there. And then sometimes the science is ahead, but our brains haven't caught up with it. So, we'll just continue to evolve. One of the other things that you pointed out is that there's certain age groups that have certain testing, and the current guidelines say that after 65, based on certain criteria of a number of normal PAPs, negative HPV, that women don't need testing anymore. What are your thoughts about that? I mean, what about the wonderful crone who at 70 decides to have a new sexual partner? What do you say to them?
What I will say to you as a scientist is maybe different when I'd say as a clinician, and what I might do in my own practice, that somebody who really wants it. Maybe I'm just a softie and I'll just be like,
We all are.
okay. But what we know really about the biology, how long it takes to happen, and also the part of the cervix where cervical cancer arises is the transformation zone, that squamocolumnar junction, which when you're young is exposed and susceptible to that infection. But as we get older and the SCJ or the transformation zone sort of recedes further up in the canal, I'm not even sure what that exposure to the HPV is going to do. Are they
So
going to
let's
be
back
as
up a little bit.
susceptible?
So, what are the ages of women who typically get cervical cancer?
Cervical cancer, there's sort of a bimodal curve. Mid 30s to then like mid 50s is sort of your
Mhm.
classic age distribution. But we know, especially in areas with high HIV prevalence, they do screening younger because it can be in women in their late 20s sometimes. With good screening, however, you shouldn't be detecting cancers beyond the women in their 60s.
Got it. So, again, it's not typically a cancer of the older woman. And so let's talk about I'm sure there are folks listening who are like, SCJ, squamous columnar junction. What? Can you break that down a little bit so that those who are not gynecologists might better understand what you just mentioned? Because I think it's really important because it says a lot about, if you will, the anatomy, but the topography that is at risk or not at risk for the HPV infection.
Yeah. And I'm not saying so if patient, and it's really important to clarify that if a woman has not had good screening,
Mm,
that we definitely need to do screening. 65 is only a stop if you've had several normal negative HPV, negative PAPs.
that's right.
So
That's right. It's
we do,
not a permission to continue not getting screened. That's not what we're talking about.
yes.
Yep.
So I guess I can describe the cervix sort of looking like, could we call it when you're in your teens, like a frosted donut?
Yeah, why not? That's an
Why
easy image.
not? So it's the cervix is the neck of the uterus. And what we as gynecologists do in put in the speculum, and you can see the cervix, and then there's a little hole in the middle that has tissues of where the cells change from glandular cells to epithelial cells. And that is the area of risk. And that area kind of looks like that glaze on a donut. But as women get older, it becomes a very, like, it can even look like a little, like a much tinier little hole. So those areas that are susceptible kind of go deeper up into the canal.
The glaze is deeper in.
Yes. Sort of like an
Yeah.
eclair.
Still juicy, but just different.
Just
Uh,
different.
yeah. So again, what Miriam is describing is that there's places all over our body where there's cellular types that are more susceptible to inflammation, more susceptible to infection, more susceptible than other cell types. And they may be right next to each other. As with the cervix, these tissues, these two different types of cells are literally adjacent to one another, but they're constantly shifting. And it's in that area of change, shift, transformation is the word we use, that risk can exist. So thank you. I like the donut image. It's
I
it's an
don't even
easy
know it.
one.
That just popped into my head.
Oh, I use it all the time. It's like it's not quite a tube. And the hole that Miriam is talking about is the hole through which menstrual blood comes. That's what dilates when we have babies vaginally. It sounds perhaps simplistic that we're talking about the anatomy of the cervix, but there are plenty of women listening who are not really clear about their cervix. So I think it's important to take it down to this cellular level. There's something that all of us are beginning to hear about, but you know all about, and that's this self-testing, that women are going to have an option or opportunity to maybe avoid their gynecologist, I don't know, but to do HPV testing on their own. Can you talk to us about that?
Yeah, it's actually been around for a while. Like I said, I think they've been doing it in Europe for at least 10 years. But the idea is that the HPV infection is in the cervix, but it is then also in the vagina. So women can take a little swab that looks like a Q-tip, put it into the vagina, rotate it around, and get a sample, which can tell us if there's HPV or not. And as a public health person, what's really exciting about that is the reassurance of a negative test.
Right on. Yeah. Yeah.
So if you have negative HPV, your chances of developing cervical cancer within the next 5 years are less than 1 in a million, which is really powerful.
That's very reassuring numbers. Yeah.
And I'll tell people that. And if they still say to me, well, I want it anyway, any clinician out there listening that's like, well, I mean, what are you going to do? And I get that. I do very much get
We all do. We all do.
that.
We all get requests for tests that we know are not based on science, but based on fear and vulnerability. And I get that. I get that. And if you can give that kind of information to someone and just reassure them, you know, it's a good thing. It's a good
And
thing.
many are like, oh, okay, if I don't need it, that's okay.
Right. Right. So let's move on to the vaccine.
But
I'm
before
sure.
we leave that, I would say
Yeah.
it doesn't mean that there aren't reasons to go to an annual exam or see a gynecologist. So I would just say there's patients that come in that we're not doing the cervical cancer screening, but we're screening for sexually transmitted infections. We're looking at contraception, menopausal symptoms.
Breast health, etc.
Yeah.
Absolutely. So in Europe, where they're utilizing this test, is it something that like you make an appointment for your GYN and they send you this vial and you do it and then the results are given to you when you go see the GYN? How is it being used internationally?
That's a great question. I can find out. I am not sure if it's at home or if it's a provider
Yeah.
collection of the self sample. One of the places with the least prevalence of cervical cancer is in the Netherlands. And I'm pretty sure they self sample at home.
Yeah. And is this something that they can go into a pharmacy and just take off a shelf?
Oh, that's a great question. Or if they get it sent to by their clinicians.
Right. I'm thinking, about the Cologuard where you have to
Yeah.
have the physician write for it. And I mean, it couldn't be more user friendly, but you still need a physician to interface with the
Yeah.
order. Yeah. Curious, curious. Yeah. So again, all of this conversation for those listening, this doesn't mean you shouldn't see your GYN. We do a whole lot more. I like to say to women, I do a whole lot more than just look at your cervix, and that there's a lot to be discussed. And hopefully it's an opportunity for you to heal in a lot of ways, not just about cervical cancer prevention or detection.
So the public health thing that I find so compelling is that if you see 100 women, probably 15% of them will have HPV infections. So women can self-swab, and 85 of those 100 women, you can say, don't worry, you don't need to come back again for a few years. So we can really decrease the number of interventions that we do for this so that the people who get cervical cancer in the US are people that haven't been screened. So I think the self collection could be pretty amazing in the community. I mean, go to your dentist's office, get it from different community settings and send the test back. It is
Yeah.
so much, it is not super prevalent like that now, but I imagine that it will be, that there'll be,
Yeah. Yeah. Let's hope. Let's hope.
yes.
Yeah. I mean, it's analogous to being able to get some contraception over the counter. Yeah.
Exactly.
So that we can all take good care of ourselves. It's such an interesting, I guess what I want to say is that in my clinical practice, what I want to point out, something you just said, is the only women I've seen with advanced cervical cancer are women who have not had screening. It
That's
is
right.
not the woman who comes in annually or even every other year or even every third year. That what I want to make clear is that cervical cancer takes a long time to develop, but
Totally.
it's women who are saying, "Oh, I haven't been in, they're 55 and they haven't been in since their third child at 32."
Exactly.
That's a very common storyline. Yeah.
Exactly.
So we're never too old or too young to have a relationship with a gynecologist as women, and that hopefully your clinician is helping guide you as to what is appropriate based on your age, based on your history, based on how often you've been seen. Yeah. So let's talk about the vaccine, and then we're going to talk about BHI. Talk to me about the vaccine. It's been around now for quite a while, and it's being used throughout the world, is it not?
It is, and it's amazing. The vaccine is going to revolutionize things. And the vaccine that we most commonly use in the US is a Gardasil 9 valent. So it has that types 16 and 18. It also covers type 6 and 11 that don't cause cancer but cause genital warts. And then, there are 7 other high risk types that it will cover. But the most important time to get that vaccine is prior to sexual initiation. We have great studies now that even a single dose significantly decreases the cervical cancer burden. And the WHO is recommending a single dose in the US. Girls prior to 15 get 2 doses, and girls and boys, actually, because there are cancers in men that can be caused by HPV, and men can transmit the HPV and cause cervical cancer in women as well. But I'm a big believer in the HPV vaccine. In the US, we can give it as early as age 9, but really importantly is to get those vaccinations in prior to sexual initiation.
So there are folks listening who are saying, I never got the vaccine, but I'm 25 or I'm 35. What would you say? And they've already had sex, and plenty of it. What would you say to them?
Then we can do catch-up vaccination up to age 45. So we do have vaccination, and most insurances will cover it up to age 45. And I would say I've even used it later. There's some really interesting data that the HPV vaccine has some therapeutic effects. So it helps clear the virus that's already in the body. So I've had patients in my colposcopy clinic that we've given vaccine to, but I would love to see most people with a uterus, I should say, get a vaccine prior to having exposure is really the best time, but we can do catch up until age 45.
And does the data demonstrate that the 25-year-old who's not had it yet but has had sex, is the one dose sufficient there too?
They need to get the 3 doses. I
They
mean,
need to get the 3 doses. Okay.
yeah.
Okay. So let's pivot and talk about BHI because, here in America, we can get rather myopic. And, some people might say, oh, only 4,200 women die of cervical cancer a year. That's nothing compared to lung cancer and breast cancer. And why is Dr. Novatt even talking about this? And, when you widen your eyes and widen your lens and you look around the world, cervical cancer is unfortunately killing many, many, many women. And so Basic Health goes to a lot of places. I know you still go to El Salvador. Can you name some of the other places where you interface with women clinically?
Honduras, Haiti, we've had clinical trials in Peru and Colombia and China. We've done some work in Belize and Antigua. Like,
Fantastic.
yeah, it's
Yeah.
really amazing.
So when you go to these places, they're under-resourced areas. They don't always have the fancy stuff we have in our clinics. And so I know there's this phenomenon of see and treat. Can you explain to the audience how you go into these areas and help women? Is it just, oh, I just take a pap smear? I know that you do more than that. What
Yeah,
are
so
you doing?
the PAP, unfortunately, in low resource settings requires a lot of follow-up. You
Yeah.
PAP, you have to get your abnormal results, you have to come back, maybe even just get the results that day, maybe go somewhere else to get a biopsy, then come back for those results, and then come back for treatment. And loss to follow-up is just really high.
Yeah.
And I think when you came with us for BHI, we did a see and treat with a test called visual
VIA
visual inspection with
inspection under
acetic acid.
acetic acid. Yeah.
And sadly, we were so excited about that test. It had not really moved the needle at all.
Mm.
And what that was pretty much putting on vinegar and then treating right away. And it's really compelling because you don't need a lot of equipment for it. And you can say, okay, so something looks abnormal, we'll treat. But I think there's so much subjectivity in the exam, and it's very hard to scale. So, what we're really trying to move towards is HPV testing. And
Mm.
I have built my career working with engineers on low cost HPV testing. So women can self sample. We have a portable machine so that women get their test and they wait. And then the ones that are positive, we can treat right away. So we can provide reassurance to those that are negative. And we actually do treatment of the HPV positives that same day, which is
Fantastic.
pretty great.
So you're treating these pre-cancers that we spoke about earlier.
Exactly. Those who are
Yeah.
eligible for ablation,
Right.
say we do
Right.
it the same day.
Right.
Pretty.
So are these women getting exams in addition?
So we have our clinical trials. All the patients that are HPV positive get an exam with a speculum. And then we have a really cool app that you can take a picture and then you get a risk score. So like AI is everywhere, but I think these new technologies can maybe help guide treatment. And because not everybody with HPV has precancer, but because rates of follow-up are so low in these places, we do offer same-day treatment to those who are eligible because we know that will decrease mortality. But if we can decrease the number that we have to do, I think without a lab, there's really like using the camera to take a picture is pretty amazing.
Yeah, it's remarkable. Which brings me to, I guess, what is on the cutting edge now? What research are you doing in addition to this camera that folks might be curious about that might come to the States, but also certainly to under-resourced areas?
I love the work we're doing because I don't love research for research's sake. I love tools that will make a difference.
Yeah.
So exciting. The AI stuff on the horizon is exciting. And then my passion has been treatment because you can have the best screening test in the world, but if you can't offer immediate effective treatment, you're still in the same spot. So
Yeah, you still have that 30-year-old who's going to bleed to death.
exactly,
Yeah.
exactly.
Yeah.
So I've been working with a couple different engineers on so the way we treat cervical precancer in the US is generally with excision methods. So we remove that transformation zone. That requires a skill. It can be dangerous. It's hard to do in the field. And so the most common method of precancer treatment in low resource settings is ablation methods that historically were done with freezing the cells called cryotherapy, which takes probably about 15 minutes to treat. What I've been working on is instead of cold, we use heat in
Mm.
a method called thermal ablation. And you can treat someone in just like a minute or two. You do applications of the thermal ablator. And I'm really interested in what the shape of the tips look like. I won't go too far down that road because I'm sure there's not that many people, but it's really what's exciting about it is it's quick. The thermal ablators, like with a cryotherapy machine, you use a tank of gas. They're heavy. It's you have to get them refilled. The thermal ablator is less than 2 pounds. It's can fit in your backpack and you can take it anywhere. And it works on a portable battery. So there's really no excuse why anybody should not be getting their screening and treatment.
Great, great. I just had this wonderful picture in my mind of clinicians, practitioners all over the world, with their backpack and their thermal ablation and just eradicating cervical cancer. I
Yeah,
mean, this is possible.
it is.
So I just am so grateful to know you and know your work. And I so applaud you because it's not hard to imagine the 30-year-old leaving behind children as a result of just not having access, agency, awareness, a community that knows how to take care of her. And not because they don't want to, but because they just don't have the resources.
And I would tell you that, in some countries without resources, it is actually the leading cause of cancer death. We just did some work where women were coming from the little islands in El Salvador, and they came by boat to get their screening and treatment. And women will come because they know somebody that's died of cervical cancer. They've like all of them have had these experiences. And super excitingly, since the times that you were there, we actually have done a program with the Ministry of Health in El Salvador. We now do HPV. There's a national HPV screening program.
Mm,
And so now we're just trying to get it to, that woman at the end of the road, trying to make sure that everybody gets screening and treatment when they need it.
great, great. So I'm coming to the end of our conversation, and I guess, if you had to identify, and some of it's obvious, but what are the greatest obstacles in supporting women and their health, you think, here in the US and abroad?
I mean, it all comes down to access
Mm,
and fear. So I think it's really important. We have this model today where we're seeing people and not given the time to adequately listen. And there are many reasons that people don't want to see us. And in some ways, I don't blame them. It's a pretty impersonal process, and a 15-minute visit is definitely not adequate. So that's a barrier. But now that all these people losing their health insurance and having to pay out of pocket, and life in general is so expensive anyway, that like it's just one more thing, it's heartbreaking to me.
It is. It is. Because we are so-called resource rich in this country, and yet more and more individuals are without the care that they need, want, should have access to. Yeah.
Yeah.
So when you are not doing the work you're doing, tell me about one thing that gives you great personal pleasure.
Ooh, what a great question. I love hot yoga. Makes
Fantastic.
me so happy. It just
Yay.
everything.
Yay. I wish you many opportunities to get sweaty during your asanas. And I really want to thank you for your time and your expertise and your willingness to kind of break down what feels really scary to a lot of women and and unclear to a lot of women. And I hope that women listening share this information with their male partners because they have a role in this too. And thank you, thank you, thank you.
Yeah, so everybody, please, if you haven't gotten your screening, get your vaccination, and hopefully it's not so scary.
Yeah, yeah. And thank you to Jan Hammoud and Maddie Rosenberg, my co-producers, and to David Hoffman, my editor. And to all of you listening, please stay well. And please listen to your instincts and your intuitions. They are the greatest of teachers, not to be ignored.